هلا شو كثير لا لا ما في شيء للهيدا سلايدز كله تقريبا لا اتس اوكي بس تو نو كله هيك اوكي sorry فيني شيء لهيدا معها okay so good afternoon. So I presented myself during the orientation. I think most of you were there, but you were virtually there. So my name is Monique Shaya. I'm the coordinator of this module, which is the FP. And as I told you earlier, that there will be 4 of us, and I think this enriches your course. So you have already met Dr. Sibai, who's going to also come for another session on validity and reliability, and you have أنا محسوبتكم Monique Shaya. I'm a professor of epidemiology. You have also Dr. Martin Al-Birjani, who's primarily at the CRI, which is the Clinical Research Institute at AUBMC, and Dr. also Marlene Shakhtoura, attending endocrinologist and also a researcher who will be giving you the RCT. Okay, so of course, the way it's divided, we have like, I'm going to give 2-3 lectures, I'm going to give the outcome and then the association and then come for the interaction. It's actually divided based on our expertise and as well as our availability during the summer. You're available 7 weeks, where actually all of us are also into other tasks in the summer. So you have been introduced to epidemiology, right? And now we're going to look at the measures of occurrence today. So measure of occurrence in terms of when you think about epidemiology, so the first aim of epidemiology is to study the distribution and determinant of the frequency of diseases, or when the diseases occur. So we want to look at that frequency of diseases. And this is a roadmap of what I'm going to cover. So you have the calculate measure of disease occurrence in terms of incidence and prevalence and odds. Describe the relationship between the incidence and prevalence. We will look into all kinds of mortality rates, crude, adjusted, and specific mortality rate, and undergo or learn to do standardization, both direct and indirect standardization. But before going into measures of occurrence, I'd like to also draw your attention to disease entities or health outcomes. So we want to call them outcome. So these are outcome measures. So we want to look at relapse after a certain event. We want to look at survival after breast cancer diagnosis, so on and so forth. So these health outcomes are measured differently. Now, broadly, we can measure them, or we can classify them as discrete event or continuous event. So discrete could be either the event occurred or did not occur, or different levels of occurrence, or for example, number of accidents. So it could be discrete in terms of either number of accidents, or it could be, let's say, simple occurrence, not occurrence, but it could be as well a continuous measure of outcome. You might be interested in the level of blood pressure, not simply hypertension and not hypertension. So if we also revisit another classification of the disease, and this is something that you took in biostats, so I'm not reinventing the wheel or not addressing again, but we can broadly, in epi research, talk about categorical binaries. So many of the things that we are interested in are actually dichotomized. Yes, occurred, did not occur, die or survived a certain event. Categorical polynomial variables. So sometimes you don't have a strict definition of a disease, or disease occurred or not occurred. It could be, for example, if we talk about depression, it could be no depression, probable depression, or definite depression. So you have 3 categories of that variable. Again, polynomial, it means that there is no order, but it has more than 1 category, and we have to be careful about it. So how to measure, what kind of outcome you are measuring. It could be as well an ordinal variable, such as obesity. So an outcome, health outcome as obesity from underweight to overweight or morbidly obese. Discrete number of accidents, VAS, visual analog scale, which classifies pain from 1 to 5, or acuity level in a hospital, so severity level when patients come to your unit. or continuous variables such as blood pressure, glucose level, body mass index, and kilogram per meter squared, so on and so forth. However, most of the focus in EPI is going to be mostly on outcomes that are binary. So the disease occurred or did not occur, people survived or did not survive. So the event is a binary, although we would look at the time when the event occurred, during a certain period of time, or exactly the time at which an event occurred, but the variable or the event remains whether the event occurred or not occurred. So what do we do when you have continuous variable? And I'd like to talk about it a little bit. So when you have hypertension measure, sometimes you say that it's much easier to dichotomize hypertension. So you take blood pressure measure and then you say 140 and above, this is hypertensive. Less than 140, we're talking about systolic blood pressure, is hypertensive. But again, you might lose a lot of information, because what is a 139 and the 141? So as long as you are aware that this is a broad classification of hypertension, you can do it. Otherwise, you can keep your work as continuous. But we do a lot because it's much easier to talk about an occurrence of the event, whether it occurred or did not occur. So the focus, we said, as on the binary. And with binary, we have two basic measures of occurrence, which are incidence and prevalence. And they depend a lot on why am I using it? What do I want to report? Do I want to report the burden of the disease? So the burden, or how many cases exist right now or over a specific period of time, this is prevalent. Okay, so the burden of disease that you hear about, that tells us, for example, what are the most common causes of morbidity, disability, etc. They rely on prevalence. Why? Because we'd like to know how many people are living actually with the disease, and therefore how much they need services. However, if we want to look at more the risk of the disease, look at the risk factor of a certain disease, we would like to see how many people develop the disease or at risk of developing the disease. So these are measures of incidence, and they are mostly used for primary prevention and, again, etiological application, meaning identifying risk factor. So if we look at, I left you an article on COVID. So this is something different data from the recent COVID pandemic, and you see the use of EPI measure of occurrence in this COVID-19 pandemic. So the first, this is the first graph that talks about daily number of new positive cases. So we're talking about incident cases. So how many new cases occur, okay, over a period of time. So this is the time. This is a number of cases. So again, incident number of cases. So as of 19 March 2020, COVID-19 has affected over 207,000 people. So this is cumulative incidence. So up to March 2020, we have 207,000. The absolute number of deaths has already surpassed 8,500. These are incident, of course. So you died. This is the only thing that happened, and the overall case fatality rate of COVID is low. If you look at another one, okay, from Italy again, it looks at different region, looking at population, population, number of deaths, and period prevalence. And period prevalence mean how many cases developed, cured, they recovered, etc. But this is how many at one point in time, over a period, of time, how many cases we had, even though they were cured, died, or whatever. But these are number of cases. And we look at the last figure, which is the figure from the Lebanese Epidemiological Association. This is what I remember as a member of the EPI Association. We report every day what happens, and you see we can look at every day the new cases. These are the incident cases, and then we add them up to the previous cases. So we can look at the cumulative number of cases in terms of how many by, for example, 27 April, how many new cases have occurred, and we can look at by April 27 how many overall cases happened or are positive cases, which are more the prevalent cases. So we talk a lot of EPI. So let's talk about the two. So we said incidence and prevalence. Again, I repeat, incidence is for development of a disease, and prevalence is how much cases exist, or how much of any health outcome exists at one point in time or over a period of time. And we have two measures of incidence, and these are important because, again, each one is used for a different type of data or a different type of people who are followed up. So there is one which is very simple, which is a proportion. So it's an incidence proportion, or what we call cumulative incidence. We call it CI, cumulative incidence. So we take a population, so the baseline or the point of reference is a population at risk that we follow up, and over a period of time, we see how many develop a certain disease. So the issue is that we start with the population who's at risk, okay, and then we follow up to see how many have developed the disease. So we have 2 points in time. We need to have a baseline to know who are at risk, and we follow up to see during that time of follow-up or observation how many develop the disease. And it does not account for the actual time when the disease occurred. So after 20 years, I would look how many new cases, and then I would take the number of cases over the total number. The population who are at baseline was at risk. So population at baseline who are at risk after 20 years, how many new cases? This is my cumulative incidence, while the incidence rate is more of, it denotes more the rate of occurrence, which is more related to speed, and we look at it. So it's not only the issue of how many occurrences, it's how many occurrences is the rate of these occurrences at different point in time or with specific time period. So we look at the first one. So again, the point of reference for a cumulative incidence is the number of the population size who is at risk. So this is the population size who's at risk at baseline. So we have to think that everything is prospective. So you look now prospectively, and during a specified period of time, let's say 1 year, 2 years, or even 7 days, how many new occurrences? The new occurrences are new people who develop the disease, not the number of incidents, because some people might have 2 incidents. And once people have 2 incidents, they become they are not anymore at risk at the second time of the occurrence. So we're talking about a new occurrence, meaning that now that we are talking about new people who have developed the disease. Population at risk, the 10 to the power n is just a population base. So if you want to report as 403 cases per 100,000 or per 10,000, instead of looking at the probability, which is 0.001, for example. And again, as I said, the occurrences are people who develop the disease. These are, again, examples of cumulative incidence. So one is as of June 17. So again, there is a time period. We have a cumulative incidence of COVID-19 is 403.6 cases per 100,000 persons in the US. This is based on CDC data. So earlier in the article that I showed briefly, there were only new incident cases. So this is a cumulative incidence. So this is a proportion. So therefore, this 403.6 is calculated based on the number of cases as of June 17 over the total population in the US times 100,000. Okay, so number of new cases over population size of the US times 100,000. And of course, this is changing, and we'll see why it will change. 5-year breast cancer survival, so either people die or survive after being diagnosed with cancer. 94% for local stage, 18 for distant stage. Again, these are incident cases, so how many survived until 5 years, they're still alive or they have died. The chance of developing invasive cancer over a woman's lifetime is 1/8, so it's lifetime risk. Again, whenever you see a risk or you hear developing prospectively, so this is a cumulative incidence, or this is an incidence rate. And among men aged 55 to 59, 1% will have their first heart attack in the next year, and 3.8 is the next 3 years. So what I have highlighted are specific time period. So as of June 17, the cumulative incidence, it's a 5-year incidence. Okay, it's 5-year survival. It is a lifetime survival. It's a lifetime risk of invasive breast cancer, and you have a 1-year incidence and 3 years incidence. That's why it's very important when you report that proportion, which doesn't have any time unit within the proportion. It's a proportion. It's from 0 to 1. It's from 0 to 100. We're talking about percentages. You have to specifically mention the time period, because you will have more cases as you follow up longer time, right? So if you follow up people for 20 years and you get 100 cases, so if you follow up 40 years, you will have more cases. The cumulative incidence will be higher when you have a 40-year follow-up, right? Okay, so this, just some comments on the incidence proportion, is that the value increases with longer period of follow-up. So as I just said, if you take 20 years, you would have maybe 20 cases, 40 years you will have 40 cases, and these are examples. But the issue of incidence is that it does not take into account the time of the event. So we don't know exactly during that 20 year when this happens, even in the age of the woman, so in the lifetime of a woman. So when we say that 1 year or 2 years or 3 years, so when does it happen? Is it the first 2 months? Is it the first 2 years? We just know that at the end of the follow-up period, okay, we have so many cases. Okay, so this is the cumulative, it is cumulative incidence. So at a certain period of time, how many overall, but we wouldn't know exactly the time when the event occurred, or we don't take it into consideration in cumulative incidence. Another aspect of this is the competing risk and loss to follow-up. So competing risk, it means that when you follow up people and you want to see how many will develop a certain event, some of those people might develop something else that will not put them anymore at risk of developing that event. So if they die of coronary heart disease and you're following them up to see how many will develop dementia, for example, but they die earlier of coronary heart disease. So this is a competing risk. Okay, and the cumulative incidence does not take this into consideration, because they will always be considered in the denominator, and in the numerator only those who you have seen develop the disease. But those who died without developing the disease from a competing risk, they might have developed the disease if they were alive, or if they did not develop, died of coronary heart disease. But this is less of a problem when you have short follow-up period. Okay. And another one is people who are lost to follow-up. So again, we said incidence comes when you take a baseline population and then you have to follow up in time. It could be a short follow-up or a long follow-up. But what happens if people just drop out, people just disappear? Okay, if they disappear or they drop out, we will not have the chance to observe whether they will develop the event or not. The issue becomes very serious if their loss to follow up or dropout is directly or indirectly related to the event or to the exposure you are interested in. So let's say you are looking at take smoker and non-smoker and looking at coronary heart disease as an outcome, and you have more smoker who are dropout before developing the coronary heart disease or any other. So they are lost to follow up, and you find out later that you have more smoker, and the more smoker will be more likely to develop if they stayed in your study or if you have a chance of observing them. So you have to, again, look into that and look into why are they lost to follow up? Is there a particular trend? Is it done at random or not at random? So the competing risk also you have to check, and you have to check loss to follow. So what to do if we have such issues of competing risk and loss to follow up is to look at an incidence rate. So instead of looking at cumulative incidence, which is a pure proportion of number of event over population at risk of the event, I can calculate an instantaneous risk, which is an incidence rate, which is the risk of developing the event at any point in time. And your denominator is not anymore person at risk, it is person time at risk. So some people would stay 5 months, for example. So you have a 1 year, for example, 1 year follow-up, and you have somebody who comes in at time 0 and then stays 5 months and then develop the disease. Okay, so they have contributed 5 person month for the follow-up. Other people can stay through the whole year without having the event. Other people might join in the middle of your 1 year, stay 1 month, and then they are lost. But at least to take into consideration their contribution to the risk, I can always calculate how much they were, how much of their time was at risk. They were at risk until either they develop the event, so they come at time 0, develop the event after 5 months, it means they were 5 months at risk. If they come at time 0 and then we lost them for the competing risk after 3 months, it means from 0 to 3 months they were at risk. So I take this into consideration. I don't consider it as a full person who was at risk during the whole period. If people remain with me the whole year, it means they were the whole year at risk and they did not develop the event. So to take this into consideration, I do something called the rate of occurrence, which is in person year, and the unit is from 0 to infinity, and sorry, the range, and the unit is case per person time. It could be person year, it could be person month. So let's take this example and illustrate how important it is to look at incidence rate when you have competing risks and loss to follow up. Because when we look at cumulative incidence, in our mind, it's a stable population. Okay, I start with 100 and then I lose only those who develop the disease. But things are not, usually people are dynamic, they don't stay in the same even residence, they die of something else, they drop out, they lose interest. So this is an example illustrating that incidence rate by taking 5 subjects. They were followed up for 20 years from 1990 to 2010. Okay. So subject 1 joined. So we observed subject 1 for 10 years, and at 10 years that person developed coronary heart disease, which is my outcome of interest, died of CHD. So what's my outcome is death from coronary heart disease. So what would be my cumulative incidence, or the incidence is number of new cases of CHD, death from CHD. So the second subject joined the study, or I was able to observe him or her in 1995 until 2005. So how long did I observe that person? Again, for 10 years. And again, after 10 years, irrespective whether I observe him at time 0 or at the beginning of the study, but that person, I was able to observe him to be at risk for 10 years. So I call 10 person years, so that is 1 person. Subject 3 joined at 1990, and the study ends in 2010, and that person was still without the outcome. Okay. The 4th person died of cancer. So I observed him from 1995 to 2000 for 5 years. So 5 years that person was at risk, but that person did not develop or did not have a chance to develop coronary heart disease, but at least I know that for 5 years, that person was at risk. So this is an additional 5 person year. And the last subject was lost to follow up after 10 years. So again, I observed him for 10 years without any evidence of the outcome. So therefore, if I look at, and I want to say, calculate 2 measures of occurrence. So I'd like to know 2 measures of risk development. So the quickest one is to see how many had the event, which are number 1 and 2, over how many were under observation, or the population sample size. The population size, excuse me, is 5. So 2 out of 5. So 40% of my 5 subjects developed the disease, okay, or died from CHD. But if I take into consideration, instead of the number, the total number of person years that were contributed by those 5. So the first contributed 5 person years, 10, it means 10 years, and then they developed the event. So if I have 2 subjects, it means 2 times 10. So if 2 subjects died after 10 years, it means I have 2 times 10. Okay? So 10 person year is the person, 1 person, who spent how many years in the study? 10 before developing the coronary heart disease. There is another person also who spent 10 years, okay, but the 10 years, they don't have to be counted from 1990. They were counted starting the time I started observing that person. So I started observing the person in 1995, okay, and then until 2005. So that person stays under observation for 10 years without having the CHD. After 10 years, he or she died of CHD. So it means this is another 10 person years. The third one, 20 years without CHD. So what's the unit time at risk? It's 20. Yani 1 person times 20 years. 1 times 20. The fourth is 1 person who stayed 5 years and then developed cancer or died of cancer. And the last one is 10 years because the last time he or she was observed after 10 years and then he disappeared. But at least we take into consideration the time at risk. So overall, these 5 people contributed 55 total person years. كأنه tobacco years. So if you tell me how many cigarettes you smoke 20 packs, 1 pack a day or 1 pack, whatever, or 20 cigarettes a day. So for how long have you been smoking? For 20 years. So I would multiply your 20 years time, your number of cigarettes that you smoke every day. So this is a kind of example. So therefore, the incidence rate is 2 over 55 person year. So it is 0.036. Okay, so let me. لا مش laser pointer, sorry. It's a pen. I'm a little bit clumsy with this screen. Okay, I'll get better. Okay, the pen. So okay, so this is my 55. This is the number. So 2 people. Okay, 2 people died of coronary heart disease. My outcome. So what you are after, what you would like to look at is death from coronary heart disease. How many died of coronary heart disease, which is my outcome? 2. Okay, so I can either look at the cumulative incidence, which is the proportion, probability. So what's the probability of dying? Probability of dying is 2 out of those people who are at risk, which are 5. So when they were recruited or when they didn't have any coronary heart disease, so after 5 years, 10 years, etc. So this is 2 out of 5, which is 40% over 20 years of follow-up. So on the first one, because of this different competing risk and loss to follow-up, we take into consideration each person's contribution to time at risk, and therefore my denominator is not the samples, the population size, is total person year contributed by all these people, which is 55, and therefore it's 2 out of 55. Let's take the other example. It's another one. So let's take group B. So group B, so I'm comparing group A, group B. Group B come in, we have 5 subjects. The first subject developed the coronary heart disease after 15 years. The second after 10 years. The third spent 15 years without any event, so okay, no event. This fourth person, after 15 years, he or she died of cancer. So this is competing risk. This person will not have a chance to die of CHD because he already died of cancer. And the last person, 15 years, what happened to that person? After 15 years, I wouldn't find him. So I tried to call him. I asked his wife, his siblings, tried his address. He just disappeared, or he decided not to be anymore interviewed. Okay, so I don't know anything about that person. Maybe his record was destroyed. I don't know. So if you look at this one and the earlier one, okay, so we have 2 events, and here we have again 2 events. So if we're talking about the probability of dying of CHD, it's 2 out of 5, right? 2 out of 5 is 40. So if you tell me, are they different group A and group B? From the cumulative incidence, they are not. So over 20 years, the same number of cases happened in group A and in group B. But if we look closely and just this visual scrutiny, you see that in group 1, without doing any calculation, the time at risk is shorter. Yani they died, they didn't actually survive a long time. Even in those who, those who develop CHD after 10, and here after 10 years. Well, if you look here, it's after 15 years, 10 years, and they remained more, you have more people at risk. So if you do the calculation, so again, 1 person contributed 15. What does 15? This is 1 times 1 person times 15 years. Yeah. Okay. So sorry, Muhammad, 10 times 15. This is your person year. 1 times 15, 1 person. Another person times 10 person year. So he spent 10 years. person year is number of person times years, okay? 15 person year is one person, 15, another person, 15, but this person died of cancer, and 15, and the total person year is 70. So therefore, the other one contributed in the 20-year follow-up, the A, to 15 years person year of follow-up. Those 5 contributed 70 years of person year follow-up. So which is a longer, more at risk. And out of those more at risk, we have 2. So if you compare the cumulative, they look the same. But if you compare the incidence rate, you see that the speed, so we have the same occurrences, but the speed of occurrence is higher in group A, which is 0.036. Okay, or the instantaneous risk is higher because we considered actually the dynamic contribution of those people. So those people did not start with us as 100, and then people died, and then there was, let's say, 10, and then we remained with 90. There's a lot of movement, mobility of that group, and I want to take this into consideration and account for every person's contribution to that calculation, to this calculation. And therefore, the incidence rate is higher in A because we consider, so therefore we took cumulative and is a proportion. Incidence rate, the second one is called incidence density rate, where the denominator is person year, and you have a particular incidence measure, which called the hazard rate. So that hazard rate, you're not going to calculate it. This is a very special rate that we use a lot with survival analysis. Survival analysis, it means I am not only interested in looking at the rate people dying, I'm not interested in what's the proportion of people who are dying. I'm also interested in the time of death. So I'm interested in every person's time at death. The earlier one is only that contribution to the what? Contribution to the denominator. Now I'm talking about an event and its contribution for the numerator. So therefore, the hazard is the risk at any particular point in time among those who did not get the disease until that point in time. So I observed 100. So I have 20 at time 1 who developed a disease. So at time 1, how many now at risk? They're not anymore the 100, they are the 80. So now given that you have survived 1 year, so given that you have survived 1 year, okay, you did not develop, I continue to follow up now. At month 2, so from the 80, I have another 2 who died. So at 2, what is the probability? So the rate is your death rate, okay, or the probability of developing the event, given that you have survived or did not get the event earlier. And we look at every person's event. Okay, so the time of the event is important. So it is analogous to conditional probability. It means what is your probability of the event given that you didn't get that event at that point in time. So again, the time is important, and the delta t, which is the difference between time 1 and time 2, is important. And it is defined for every single point in time of the event. And if people die at 2 months, 3 months, 4 months, 5 months, I would calculate a hazard rate at every single time. The CHD is just 2 over the periods of time, the person year. Here it is, we calculate a hazard rate as every single time of occurrence of the event. It's not directly calculated, although I provided the formula, which is probability of event in interval t and t plus delta t. So what's happening between t and delta t given that you were alive at t. So t is 2 months. When 2 to 4 months, what happened? So your probability of dying or getting the health outcome, given that you have survived t. Okay, so it's a probability over delta t. So it's a hazard function. Usually it's only done through the computer, and you will be using it and seeing it and survival analysis. So let me show you a little bit how you see it. So these are 2 graphs. These are going to be very familiar to you once you're done with the EPI. So you are going to take analysis of cohort study, and one part of analysis is survival with Dr. Martin Berjani. So you're going to see this kind of graph. So this is survival. So this comes from a study on recurrence risk after curative resection of patient with stage 1 and to 3 colorectal cancer using the hazard function. So this is the title of the paper. So what's this? So what is the outcome here? What is the outcome? Evaluation of recurrence risk after curative resection of patient with stage 1 to 3 colorectal cancer. What's the outcome? Cancer recurrence. So you have cancer recurrence. So you have colorectal cancer patient. They are stage 1 to 3. They do the resection, and then you follow up to see how many, what's the probability of recurrence. Okay, so this is usually what you do with cancer, right? How many survive? If you take stage 4, ultimately 100% would die within a period of time, but it's not about dying or not, it's about the time to death. Okay, so therefore we look at the survival. So survival is, for example, at 0 time, you have everyone. So all the patients, okay, stage 1, 2, or 3, they are alive, right? You resect, they are alive. And then as you move in time, you lose patients. What do you mean we lose? They have recurrence. This is survival. So this means that here, so many survived. So here we're looking at how many would survive. And this is what you hear, survival rate of breast cancer. How long will a cancer patient survive? You as the medical doctor would tell the patient that the median survival time is 6 months. Isn't it what you hear as at least health professional? Now, if you look at the hazard, instead of looking at how many will survive, is how many they die. Actually, how many have a recurrence. And this is how many are recurrence. This is the hazard rate. This is something that you will see, that you will not calculate yourself, but it is a function based on Cox regression, is a regression analysis. And then you will see how many. So if you look at the 3 ones, you see that those at stage 3, of course, have a higher recurrence, but you can see the recurrence at every single month, at every single time of the disease occurrence, all right? So you don't have only one, but you see it as a function. So this is the hazard rate. So what affect incidence? Of course, if the incidence drops, now if you have a proper control of a certain disease. So if you have a proper control of diseases, even like risk factor of diseases specifically, that's why we talk about risk, we talk about prevention. So if we have good tobacco control laws, if we have good control of environmental pollution, so on and so forth, we should expect to have lower cancer or CHDs. If we have good, we reduce the salt intake, and we have policies, overall policies to reduce salt intake, we should have less hypertension. So this is the incidence, okay? Now, what would increase the incidence? Of course, if we have to always be careful, sometimes improve reporting. So not because we have a higher risk, but people are reporting, we have better diagnostic tools, we have different diagnostic criteria that is actually detecting a larger number. Sometimes they lower the cutoff for HbA1c, for hypertension, etc. Let's say if they lower the level where people are diagnosed or labeled as hypertension to 130 over 80, for example, or 120 over 70, so you would expect more hypertensive. So change in diagnostic criteria, a change in the reporting, for example, improve detection again, or sometimes if you get more people coming into your population who are more at vulnerable population. So the more vulnerable population coming into your population for a certain risk factor, you are more likely to have a higher incidence. So this is with respect to developing the HEDA. So 2, incidence rate, incidence density rate, cumulative rate, and the particular important measure, which is the hazard rate. And then the prevalence is how many people actually live with a certain disease. So again, it measures burden of a disease. Okay, why burden is this? This is important for allocation of resources. So if I want to go and negotiate with the Ministry of Public Health to put some money into a certain chronic disease, CHD, cancer, diabetes, autism, whatever, chronic disease, for example, they have to say how many people live with that disease in order to allocate resources. So if they feel that there's a high prevalence of a certain disease, while we have like 20 or 30% who have hypertension, so they would be more likely to allocate resources with high prev. So the prevalence of disease, again, it's a proportion similar to the to incidence. However, in your numerator, you have everyone living with the disease. So it could be a new case or it could be an old case. So it's number of new and old case over at a certain period of time, over a period of time, a lifetime risk over total population or mid-year population. So it is, again, a population size and it's a proportion. So example, out of 100 patients hospitalized with stroke, 18 had ICH. So this is when you hospitalize patient, you do their exam and you find out how many have ICH. Or prevalence, let's say the prevalence of HIV in Lebanon is 8 per 10,000. So at any point in time, the prevalence of HIV is 8. Okay, so we have to specify when is that anyway. So you do a cross-section study, you take a representative sample and you find 8 cases, so 8 out of the number of the sample size times 100,000 and you have 8 per 10,000, for example. So new and pre-existing cases observed at or during specified period of time over total number of subjects at or during a specified period of time. And the power of 10 can vary, depends, so per 10,000, per 100,000, this is what we call population base. So another example, yeah. يعني period prevalence, يعني أنت بتقول مثلا during the period April 1 to April 15, how many reported whatever. So that doesn't have to be a new case. It could be just an old case, but this is during a period of time. We can see it right now. So prevalence of student wearing eyeglasses among sharp students. At this point in time, I can just look and see one person. I don't see the other who are virtually with us. So this is the number. So أنا مين في بعد حدا؟ ما شايفة يا ولد هذه للقريب. Okay. So this is 3 out of out of 33 or 32 or whoever is attending. So at one point in time, what is the prevalence of student? Prevalence of breast cancer in a certain community. Again, you do cross-section study. You ask people, have you ever been diagnosed? Have you ever been diagnosed with breast cancer? And then this is prevalence of breast cancer. You go, you take their blood pressure, you measure their blood pressure. It doesn't have to be a new hypertensive patient. So when you measure the blood pressure and you classify your people into high blood pressure and low blood pressure or normal, so the prevalence of high blood pressure in a certain community in a certain time is the number who measured more than 140, let's say over 90, and the total would be the denominator would be the number of people you have investigated or you have surveyed. And the prevalences are of 3 types. Most of what you hear is the point prevalence. So you go and collect data and you say, at this point in time, I have so many who suffer out of the total population. So prevalence of the disease at a certain point in time. So do you currently smoke? That's why it's important when you collect data and you have and you want the measures of, for example, of smoking. It's very different than you ask people, do you smoke? What would be the prevalence of smoking? Do you smoke? Okay, so so currently. Okay, so if I want to know, so are these only the smokers? So I might be interested in, have you ever smoked? So these people, when they say, do you smoke? No, I don't smoke. But these could be ex-smoker. So can you capture lifetime smoking? No. So we have to ask, have you ever smoked? So I always start with, have you ever smoked? Do you currently smoke? Have you ever? Do you currently? Have you ever is a lifetime prevalence? Have you ever had a drink, a binge drinking where you were, for example? Have you ever done drugs? Hard drugs? Have you ever done weeds, etc.? And then prevalence of disease within a specified period. So have you used alcohol in the past 30 days? It could be also smoking or water pipe smoking. So did you take a water pipe or did you smoke water pipe in the past 30 days? This is a period prevalence. So this is an example of prevalence of dementia by age in Lebanon. So we had, again, cross-sectional studies. So cross-section studies are used to measure prevalence. Okay, so in a cross-sectional study, we asked people, so a battery of tests, and from that battery of tests, we were able to classify those older adults to have dementia or not have dementia. Okay, so this is at one point in time, how many are living with, not demented, but are living with dementia, and that prevalence increases with age. And we know that after the age of 30, almost one over three would be living with dementia. These are not new cases that are occurring. It's a cross section. We had people who were 65 in 2014, and we ran the battery of tests, and this is what we report, which is dementia prevalence in the EMR, and this is the hard one is for Lebanon. So let's see, so incidence or prevalence. So 30% of study subjects were taking aspirin at baseline in a clinical trial. Okay, so at baseline, anything that's at baseline, it means when they come to your clinical trial, you ask them how many of you are taking aspirin. So at baseline, you ask how many are taking aspirin. Do you have hypertension? Have you ever been told that you have you ever had headache? Do you have headache? So all these are prevalence. Non-fatal MI by first year of clinical trial study, 5% in placebo, 3% in experimental. This means that you start clinical trial, in 1 year you have 5% who had an MI, developed an MI by 1 year in the placebo, and 3% in the experimental. This is cumulative incidence. Are we all fine? Okay, I'm not able to know. So how can I entertain with the others? Rima. Okay, how can I entertain with the others? So they have to just unmute. And so if anyone wants to answer, please feel free and unmute your microphone and say. So around 10 new cases of motor vehicle head injury are admitted to the ER every weekend. It's cumulative incidence, okay? So we have someone in the classroom who's answering. Your name, please? Salim. Salim is 1/3 of those in need for treatment for mental health reported ever seeking professional help. So we do a study, we ask them, do you suffer from depression? Have you ever suffered from depression? Yes. Are you seeking treatment? Are you currently seeking, or have you ever sought treatment? And 1/3 only are seeking treatment. So this is lifetime prevalence, ever seeking. Have you ever sought a treatment? This is ever as a lifetime prevalence. Proportion of older people suffering from cataract in a cross-section study. It's point proof because it's at the time of the data collection, so many had cataract. You know that cataract is, again, have you ever had cataract or do you suffer cataract? Around about 20% had ever used any illegal drug in the past year. Period prevalence, and 5% of the non-smokers started to smoke during their first year of college. That's an incidence. These are new cases, first year, okay, of non-smokers. So, key here non-smoker, but so your cohort of students are a cohort of non-smoker. In the 5 year, 5% of those non-smoker they started smoking. This is incidence of smoking among non-smoker who join. Yes? Cumulative incidence, right. So let's go back. So we have prevalence, incidence of follow-up of clinical trial, 10 new cases admitted to the ER, this is incidence. 1/3 have ever sought treatment, this is lifetime prevalence. Proportion suffering from cataract, this is point prevalence at one point in time. 20% using illicit drug, this is period prevalence, and 5% of the non-smokers started smoking. Because these are non-smokers who started smoking in the first year, this is incidence. What affect prevalence? Of course, if you have more people at risk coming in to your population, and it's a high so influx of okay, so increased prevalence. So I'm starting with the right side. So increased incidence. Okay, so let's start with the slow recovery time. So if people take time to recover or they don't recover at all, you have a higher prevalence. Lower mortality, again, why do we have a high prevalence of non-communicable disease? Because people are living longer with chronic diseases because of improved treatment. increase incidence. So you have, for some reason, you have a new risk factor, you have a new agent, etiological agent, and it's boosting the prevalence, the disease. Exodus of non-cases, so non-cases are going out, and therefore you have more, what's in the population are more the cases, so this more, you have smaller denominator of non-cases, influx of cases, and better reporting. But what can affect also reducing prevalence if you have a faster recovery? So we know that COVID-19, usually people are recovered. We have case fatality rate, of course, a small rate or small proportion of people who died. However, people do recover. So you have high recovery rate. So you don't expect to have a high prevalence after a while. High mortality. So this is an exodus from the population. Decreased incidence, so improved the control of the disease. Influx of non-cases. So you have non-cases. So you have that will decrease your prevalence and improve of the cure rate. So those prevalent are not anymore. So when you go to them, unless it's a lifetime prevalence, it will remain. But if you ask for point prevalence, if you have an improved cure rate, you have a better prevalence or lower prevalence. So what's the link between prevalence and incidence? Actually, there is a mathematical function between incidence and prevalence. And that mathematical function is incidence time duration, but this is not it's not like a simple, so you take what's the prevalence times duration. This comes from actually a mathematical expression that's only used in steady state. What is a steady state in a population? Steady state in a population meaning that, first, that the population is not changing, and the cure rate is similar to the incidence rate. So the same proportion people are getting better, and the same proportion of people who are getting the incidence. So that particular this particular assumption of a steady state usually is rarely reached for any type of disease. Okay, but if you assume that you have a steady state where you have the cure rate is equal to the incidence rate, where your population does not change a lot, your prevalence is a function, okay, of your incidence and duration. Okay, so the longer people live with the disease, the more prevalent, right? Okay, so that's why we have high prevalence now of hypertension, coronary heart disease, while early on we didn't have that high prevalence, not because it was not prevalent, but because people would die early. So they are, this is the exodus because of mortality. And the incidence, of course, if you have a high incidence, even if you have a short duration, so you might have a high prevalence of disease if you have too many people who are getting the disease. So this is the incidence rate or the risk. So if the risk is increasing, the prevalence is increasing, but it's a function of both duration and incidence.
دكتورة مش هالفورمولا يعني الكيور ريت الزيرو؟
يعني لا مش الكيور ريت is قد الانسيدنس ريت. يعني قد ما ناس بيطلعوا قد ما ناس والان هي ذاتها. So you have an end population that's stable, and you have people who are being cured and people again who are being replaced. Okay, قد ما عم بيطلع قد ما عم ينزل. بس هيدي again, as I've said, this is a mathematical expression, and actually the expression تاعلكم is not the prevalence equal incidence times duration. If you want to look more into it, it's actually the prevalence odds, يعني prevalence over 1 minus prevalence, 1 minus p equal incidence times duration. And p over 1 minus p equal p when your probability is low. So we're talking about a disease that has a low prevalence. So with the low prevalence of disease and a very stable population with cure rate equal incidence rate where you reach that population. And this is the simplest that we put that. It is a function, but we can say that it's a function of incidence and duration. Of course, we know that the longer you live with the disease, when you go and you want to check, you find more prevalent cases. مظبوط? So high prevalence does not mean, again, high incidence, but again, you have to think about it. And that's why this is important to know. Because what we do is that when we want to look at risk factor, when we say risk factor, what does it mean? So we want to investigate or assess factor that increase what? The risk of a disease. So when we want to remove smoking, when we want to remove any type of any bad exposure, okay, so you want to remove it so the disease does not develop, right? So you have to be careful when you study, when you do a study, a cross-section study, what you are able to measure is not incidence. One point in time, are you able to measure incidence? No. What do you measure? Prevalence. Okay. So when you relate your risk factor to the prevalence, it's not the same. So you are not relating your factor to the prevalence. You're relating it to the duration, not to the risk of development. So the prevalence is a function of what? Of survival, so you live longer, and with incidence. So when you relate the occurrence of a certain disease with the risk factor, that risk factor, if you take prevalence, it doesn't mean that this factor is increasing the risk of the disease. It might be increasing what related to the living longer with the disease, but not developing the disease. So that's why you have to be careful when you relate risk factor, your outcome, the best outcome would be an incidence rather than a prevalence. And when you don't have any incidence because you cannot follow up a certain population, you have to think that this is not actually, the relationship is not a direct relationship of smoking to dementia. We say smoking is protect from dementia. It's not because they protect from dementia, because smoking affect, they have premature death from other diseases. Okay, so the people who are living with dementia also might be different people than those who have died of CHD and didn't have a chance to develop dementia, something of the sort. So you have to be very careful when you relate your risk factor to a prevalence rate rather than an incidence rate. Okay. Well, again, low prevalence does not necessarily mean low incidence, but it could be that people are getting the disease, either they are being cured directly or they are dying of the disease. So when you go and do your survey and you don't find enough and you have a low prevalence, again, low prevalence does not mean a low incidence. It could be that people are dying from it. Okay. So rapid, fatal, or cure, actually. Again, you have to think about the duration of the disease is important. ما بعرف what's happening to the people. Are they're still hearing me? So just comparing prevalence and incidence. So prevalence is, again, it's easy. It's one measure at one point in time, and then you have, it's a proportion, very easy. What's the probability of having, what's the probability of ever having a certain characteristic, a health outcome. Incidence actually needs 2 points. You need 2 measurements. So you need to make sure that the population you are measuring in terms of incidence is free from the disease at baseline. This means that you have to check their baseline status, and then you follow them up in time to see how many develop the disease. So this means that you have at least 2 observations. Prevalence is a static concept. It's a measure. It's how many have. It's how many exist. While incidence is actually more instantaneous risk. It tells you about the speed of getting a certain disease. So it's a dynamic concept. And why do we use prevalence? We use prevalence to describe characteristic of population or patient upon entry into a trial, for example, in clinical studies. While incidence are the number of new cases when we're talking about clinical data, to follow up to see how many number of new cases. So for incidence, 2 things. We have definitely to define an onset. Okay, so we need to know, we have to have a baseline and we have to define the onset, and then we have to have a period of time, a sufficient period of time where people have the chance to develop that kind of disease. That's why sometimes if you have disease that have long latency period, so we don't do a cohort study, but we do maybe a retrospective cohort or a cross-sectional study. So we don't start with, if we know that I have, for example, low incidence, I need to follow up a long period of time to have enough number of disease. So I need to have sufficient time for morbidity to appear. So these are food for thoughts. You can just go over them and see that if you can at least think about them and have answers for them. And if you don't have answers for them, you ask me. So there are over 3,500 living with AIDS. Is this good or bad news?
And travel.
Okay, but is this good or bad news?
حسب قديش population.
Okay. So we need to know. This is the, yes, so it's about also the number of population, right? And if we say, if we're talking about the COVID-19 and we're looking only at the new number of cases, it doesn't tell you anything unless you have a cumulative incidence and see the rate and the population. And we'll talk about it later. With the new emerging Syrian crisis and the influx of refugees, what's the impacts on prevalence of diseases?
حسب الريسك فاكتورز عندهم.
مش risk factor, I'm نحكي prevalence of diseases, so it depends on the disease. So if we're getting, so you have to ask me what type of refugees, what's their age group? So if we're talking about pulmonary heart disease maybe, or hypertension, if we're getting adult or older adult, the prevalence would increase. Why do we have to care about this? And refugees, they're coming, they're having prevalent diseases, especially chronic diseases, interventions, use of services, etc. So you have more people who need medication for chronic diseases. Right? So what's the significance of measuring prevalence in general? What's the significance of measuring incidence? You have to think about it based on what we said, and which is more important for public health and which is more important for assessing causality. So public health, prevalence, and causality. Again, as I said, if you're taking an outcome and your outcome measure is a prevalent and you're looking at risk factor, you have to be very careful. Are you really looking at the risk factor of the disease by taking prevalent, or because prevalent is it is a component, it's a function of both the incidence and the duration, and not only the incidence. Okay. بعد في بس واحد odds of the disease. Odds is something that's not very intuitive in terms of people. What's this odds? Odds, yani your chance of having it over the chance of not having. So having the disease over not having the disease. It's not a probability, because it's much easier to understand a probability, which is part of a whole part, rather than part over no part. Okay, so, and we use it a lot in lottery and chances of winning or losing. So you have 5 chances of losing versus 7 chances. So but anyway, it becomes interesting, and I want to go quickly when first we use it as a ratio of odds, because a ratio of odds, or the odds ratio as a component or as a measure or as a statistics is used a lot when we look at measures of association, and it is generated by analysis called logistic regression, which is very easy analysis to run when I have my outcome as a binary, and it happens or does not happen, obese or not obese. Okay, so instead of using proportion, we use the odds, an odds ratio, which is another measure. We don't use it a lot, we don't use it as a single measure of occurrence, but it is a measure of occurrence. It is your chance of having the disease over your chance of not having the disease, but it's not something that you use as an odd, you use the odds ratio. Okay, so I'm going to, so again, as I said, it is being used, it is important, the odds are important, the ratio of odds are important when we use specific study design, which is case control study, but specifically also when we use logistic regression. It's a kind of regression analysis that generates odds ratio, which is a measure of association between a factor and an outcome, an exposure and an outcome. Okay, and when we have a small proportion, so the probability or the odds is actually equal to a probability. So if your odds is 5, so let me give you an example. So we have a proportion risk of 0.2 and 0.1. So the risk ratio, so the ratio of risk is a probability, right? So the risk is the cumulative incidence risk is 0.02 over 0.1. So this is actually 0.01 and 0.02. Whenever we have a risk that's less than 10%, we can call that this is a small risk. Okay, so any outcome that is less than 10%, some people would argue this is very arbitrary, so less than 5 or less than 10%, this is a rare occurrence. So when a probability, when an outcome is of rare occurrence, the probability is equal to the odds. And an example, so the odds ratio or the risk ratio is 0.02 over 0.01. So this is the probability it's a risk, it's a proportion 0.1, 0.2. So the risk ratio would be 0.02 over 0.1, which is 2. 2 means that if you have a certain risk factor, you are two times more likely to have a certain outcome. Incidence. So these are proportions. Risk, cumulative incidence. It could be cumulative incidence or a proportion, prevalence rate. So these prevalence rate, whenever they are very small, so your odds, which is probability over 1 minus probability, which is having the disease or not having the disease, would be equal to the probability of the disease. Why? Because the 1 minus probability of the disease would be very small. Similarly, like here, so we have an odds of 0.2 over 0.98, which is equal 0.0204. And then there's another odd, which is 0.1. So this is having the disease prevalence, and this is 0.1 not having. So again, this is cumulative incidence 1, this is cumulative incidence 2. Okay, so the ratio of 0.02 over 0.01 equal to. Now let's take another odds. So the odds of having a prevalence of 0.2. So what would be the odds? It would be P, which is 0.02 over 1 minus P, which is 0.98. So this odds come from the P over 1 minus P, which is 0.98. Another one, when we have a P of also 0.1, the odds is P, 0.01, over 1 minus P, which is 0.99. And I'm dividing by almost 1. And therefore, it is 0.0101. So the odds ratio, the ratio of odds is 2.02, which is very close to the risk ratio. So the odds is equal to the probability so the odds ratio is very equal to the ratio of probabilities or an incidence or prevalent rate when the prevalence of the disease is very rare. Anyway, we'll see it in the measure of association. So its proportions are small, risk and odds are very similar. Okay, so I'm going to look at my timeline. So we are at 4:40, and we should have covered 4:40. Okay, so measure of mortality. So we still have 20 minutes. So if we're not done by 20 minutes, we can continue tomorrow before the session on. So tomorrow we have an application session. So we'll continue tomorrow, and then you will be divided into sessions. But I can at least quickly go over all the concept that needs to be covered right now. So now we're talking about mortality measures and standardization. So that is an outcome, right? It's an outcome. This is the only outcome that is 100%. We're sure that, so there's no probability. So everyone, the probability of everyone dying is by certain age is 100%. So this is by the end, بعد عمر طويل. So of course, mortality measures are very important, and they are important health indicators for nations' health status. So if you want to know how healthy are a certain population, I think you go into looking at their mortality. And the mortality could be crude, which is overall mortality. So what's the mortality, how many are dying out of the total population? But you can also look at how many females are dying, males are dying, how many are dying from a certain disease, how many are dying in a certain area, how many are dying in a certain age group. So you can have crude mortality rate, which is total number of people who die over the total population, mid-year population, and one mid-year, because we consider that we start, let's say, with 100, and then we have people who died. So let's take an average population. We average the population. So we call it mid-year population. So crude mortality, therefore, is what's the proportion of people, probability of people dying in a certain population. We can, again, look at the cause or the age-specific mortality. Proportionate mortality rate, what's the proportion dying from a certain cause out of those people, all people who are dying, so therefore death, and how many are dying from a certain cause. And case fatality rate are for those people who have a disease, how many are dying of a certain disease. And we're going to look at direct and indirect standardization. So whenever we are not interested in heterogeneity of the population, it means we ignore if the population is young, old, living in certain polluted area, the age group, young, not young, what kind of disease they have. So I just want a crude mortality rate. So it's a simple number of death over in a 1 year over number of person of population in that need. This is annual mortality rate from all causes. Again, always times population based. Usually we report annual mortality by 1,000. So if we have in Lebanon, let's say 40,000 people who died, what would be my mid-year population? Like 4 million. So 40,000 over 4 million times 1,000. This is my crude mortality rate. But if I want to exactly understand what people are dying of, so we look at cause-specific mortality rate. So cause-specific mortality rate, again, these are what? What kind of rate? What kind of, it's an incidence, it's a cumulative incidence. In the denominator, I have the population at risk, of course, at risk of dying. And then in the numerator, we have a specific event, which is number of death, which are the event. So therefore, in the numerator, now we have the number of people who died of a certain cause. So number of death from lung cancer in 1 year over number of people in the population at mid-year. So cause-specific mortality rate. The only thing in the denominator will only take the death from cancer. So this is annual mortality rate from lung cancer per 1,000 population. It could be per 10,000 population. So it is important to stratify. So we said in the crude rate, we ignore the heterogeneity of the population, but usually gender, age, residence, place of residence are very important element or very important characteristic that we use to stratify that. So therefore, instead of looking at the crude, usually we look at gender-specific mortality rate. So anytime you have a chronic disease, any NCD, when you report mortality from NCD, so annual, it's a cause-specific mortality rate, but you can as well, within current NCDs, look at gender-specific. So male-specific mortality rate. So what would differ now in the male and gender, and whenever you take specific subgroups, your denominator also should reflect that subgroup. So your denominator is not anymore all the population. So male-specific mortality rate is the mortality among the males over the population of male during that year times your population base, which is 1,000. Female annual mortality rate is out of the female in the population, that could be maybe half the population, how many deaths occur among the female over the total number of female. So age, sex, whenever we think about stratifying population into subgroups based on specific socio-demographic characteristic, your denominator is not anymore the total population as in cause-specific or annual mortality rate, but it is that the population size of that specific subgroup. So this is mid-year population of females.
Why do you take mid-year and not like the full-year population?
But again, you think that people die, so take the average population, and then you think about people going in and out. So it's like you average the population. Okay? A population is not static. A population is dynamic. And because if a population is static, if you take the mid-year or you take the population at the end or at the beginning, it will not make a difference. And if you think that there is a lot of mobility, it will not make a difference. But if you have mobility, I think this actually makes a difference. Okay? So subgroups mortality, we said males and females. I think there's twice. So again, the proportionate mortality also is important. And this is a lot important because you'd like to know out of the total number of deaths, how many are dying of specific causes. And this is actually how they classify the burden of disease. So are you all familiar with the burden of disease? So do you know the burden of disease study? Okay, so the burden of disease study that started in the 1990 by Chris Murray and I forgot the second, Chris Murray and second person, anyway, WHO. So they started quantifying the burden of disease in all the countries. Again, burden, it means prevalence. But within the prevalence, what they report is like, what are the 10 most important causes of death in a certain country, or causes of disability. So they classify. And to classify, you'd like to say, out of the diseases, what is the proportion or the part of that disease that is caused by depression, NCDs, dementia, Alzheimer's, so on and so forth. So to classify, again, the importance of the disease is also to see within all the diseases, what are the proportion of people who are dying from a certain disease. And this is the burden of disease, one of the things that we call burden of disease. So it's the death from its given cause in a specific period of time divided by the total death in the same period. So what proportion of all deaths was due to lung cancer? What proportion of all deaths in the hospital are due again to lung cancer? It means you take all lung cancer, all death in the denominator, and you see out of deaths how many have died of lung cancer. So this is proportional mortality. Again, it gives you how important your disease is, your NCD. So again, this is another example. This is the same example. So number of deaths from lung cancer in Lebanon, so I don't have to repeat it. And this is the case fatality rate. Again, case fatality rate will tell you what about the disease. As doctors, as public health professional, so why do you care about case fatality? Again, case fatality is how what the number of deaths out of from a certain disease out of those who have that disease. So the denominator is not death as in proportion to mortality. It is the number of people suffering from that disease. So why is it important? How deadly is the disease? Do you know what's the CFR of COVID-19?
2.5.
Okay, 2.2. Is it in Lebanon?
لا لبنان أصغر كتير.
Okay, so let's look at it. It might be interesting in the future.
Around 30 people. في 1600 كيس على Lebanon. Shift or control.
Shift or control. Shift and control. Whatever. خلاص فيكم تشوفوا أنتم هذا. This is something that I actually recently ended. So it goes from very low to very high. In Lebanon, it's actually 2%. Anyway, we have 34 cases, and so far 34 deaths. And how many cases so far? 1700. So تقريبا.
يعني 0.02.
يعني تقريبا 2%. Okay, so we have 2%. Okay, this is similar. It's actually very similar to. But what about the incidence? And when you see in places where we have much higher incidence, what do you think? So you're comparing حتى death, and you're comparing incidence of COVID-19, comparing Lebanon to Italy, to the US, etc. Is that simple?
Screening depends on the number of screening tests, كمان.
Okay, it depends on the screening test. What if, let's say they have the same rate of screening? So what could be an issue here? And we talk about we're much better than Italy, we're fine.
Centralized, نحن بنفحص ببيروت بس.
Okay, so what we do is مش بس بيروت, so why it's not moving? Because what we're looking as the crude, and I think the first thing that we have been talking about, what is our denominator? What's my denominator? What am I comparing with? So am I comparing comparable population? For example, in France, I think the people who were dying where? I think they were dying in nursing homes. The people who were dying in Canada, the high level of mortality, those people were dying at. So we're talking about a young population. So we have a young population compared to an older population where the risk is higher in an older population. And therefore, if we are to compare crude mortality, this will not give me the right comparison between population A and population B. And therefore, we need to adjust. We can adjust for several things. We can adjust, of course, the most important characteristic that we can adjust for, or maybe number one characteristic that we adjust for when we compare population is age, because the most important, there is the universal risk factor, strongest risk factor is age. Okay, so if we have an old population versus a young population, so therefore we have to think about what are we comparing, an apple to oranges. So we have to adjust based on age, gender, locality, use of availability of services, so on and so forth. So let's take this example. So if you look at this example, which is age and gender specific coronary heart disease death rate in Lebanon, this is 2008. So if we look at the overall crude rate, it's 30 per 1,000, which is fine. And 30 per 10,000 maybe. So is it good? Is it bad? I mean, if I want to compare, but if I look at category specific death rate, so in one category, actually, I have very high rate of death due to coronary heart disease. And this means that that particular age group is at high risk. Okay, so I cannot actually compare and actually get a good conclusion about death from coronary heart disease by looking at the crude death rate. So I have to look at age specific or death or gender specific. So this is another example, and we worry about crude rate when we think about something called Simpson paradox. This means that when you look at rates, that when you look at them aggregate, they actually reflect the reverse image when you disaggregate them by a certain category, like here, for example, the age of the patient. So you have here two hospitals, Hospital X and Hospital Y, and we're looking at crude death in Hospital X and Hospital Y. So if you look at just the crude rate, which is the aggregated, when we say the crude, it means you're aggregating all the data, taking the 100, the 61 over 110, and the 39 over 110. So what can you say? If we just quickly do want to make a conclusion, you would say that Hospital X have maybe poor quality of care, people are dying, the rate of dying in Hospital X is actually 55%, while it is 35% in Hospital Y. But then if you want to take it further and you are the epidemiologist and you know that the crude rate is actually not allowing for the heterogeneity of the population, so are the two hospitals catering for the same type of population? So are they sicker, for example? So you cannot compare AUH2, for example, TRAD, I would say, no? Yes, because this is a referral center where you have the more severe cases, because it's a referral center. So if you compare those two hospitals, when you disaggregate the data based on age, you find that at every, at the disaggregate or at the stratified level, so when you stratify in Hospital X, the young cases have 10% rate of dying, while in Hospital Y, the young cases have 30% rate of dying. So when you pool the data, X look much poorer than Y, but when you disaggregate the data, it's actually it's actually the reverse. So it gives you the reverse conclusion. So in here again, the old case is 60% in X, while it is 90%. So if you disaggregate, it's much better. But when you look at the totality of the data, it's actually, it gives you the reverse conclusion. So why is that? Again, so it could be misleading because there could be some differences. It could be differences across population, or even sometimes when you compare, you can compare population at Lebanon in 2001, 2010, 2020. And if you just compare, again, the population can be very different, and it should be standardized somehow. So this is crude rate for subgroup of the population. I'm going to skip that because I don't think that this is very important or informative. So I would go directly to that table where, again, to emphasize that when we do the category specific death rate for young and old population, irrespective of the age, but young and old, we see that Hospital X have better mortality compared to Hospital Y. Okay, so what do we do? So the category specific rates actually are good. Okay, so they're good. So you can tell me, okay, I will not look at the crude rate, I would look at the age specific, and then I will report the conclusion that for the young people, it is 10 compared to 30, and for the older case, 60% to 90. This is easy because you only have two strata, okay, two strata, the young and the old. What if you have this kind of data? So this is a data that looks at heart disease mortality rate across time, so for every year and with age group. So it is two strata. So strata by age and strata. So this is the row are age, and this. So it's a lot of data. But can't you make some kind of a conclusion? Yes, but you have. It's not. I mean, you can look at it and you can draw a line and see how it is within a year, how it is changing in 2000, 2001. So you find an increase with age, and then in 2001, and then you can take everyone. So you can use a lot of data. So this is called category specific rate. But if you want to make a statement about it, you have a lot of data. It's too cumbersome, it's too crowded, it's too many data points to use. So what you need is you need an adjusted measure, which is only one measure that is adjusted for time and age in order to compare. Either compare by year, so you adjust by age, or you compare by age and adjust by year. So if you want to look at from 20 to 24, 25, 35, so you want to look at the cohort effect. So you have to also adjust. So either you adjust for time or you adjust for age. Nevertheless, this is too much. It's too cumbersome. This is what I'm saying. It's too cumbersome when you have large number of categories to compare. So ultimately, you'd like to have one adjusted measure that would tell you the whole story. Again, that adjusted measure is again used for comparison. So if you want raw data, it's the raw data. The crude rate is the rate of mortality of population. But if you want to compare it to other people, you have that crude rate need to be adjusted for basic sociodemographic characteristic. And therefore, the most important adjustment actually happens for age, because when you compare population, you have to make sure at least that their age distribution are similar. So in order to adjust for age or maybe other factor, instead of having age group old, young, I can take severe cases, less severe cases. I can say rural, urban. I can do smoker, non-smoker. So maybe a hospital X have more smokers, for example, than hospital Y, or vice versa, for example. So you can adjust for age or adjust for other things. So two ways of adjusting. Okay, so let me just introduce the adjustment, okay? And you can maybe read the slide, and then tomorrow I will go over the adjustment. But we have two types of adjustment, which are direct adjustment and indirect adjustment. Let me just walk you through the direct adjustment. So this is the same table as you've seen before, right? Okay, we said that when we looked, خلينا نرجع اخذ البوينتر. So when we compare this to this, we said what? This is higher, right? And when we look at the specific mortality, Heidi is less than the 30. And this one is less than the 90. But why is this happening? So let's see that population, okay? So there is an issue. So in order to adjust, I might have actually the population of hospital X and hospital Y, the numbers. But to make sure that this is an issue of age, so differences in age, I would consider a standard population where I have 50 young and 50 old. So, and this is done a lot when I'm comparing mortality or any morbidity in Lebanon compared to other countries. And if I, for example, the study in dementia in Lebanon, we had crude prevalence of 7%. So are we better off than UK, or are we higher than the UK? Are we higher than the world? So all studies that are done all over the world used one standard population to build their adjusted rate. And that population could be either Western Europe or something called WHO World Population. So as if we're saying, so if I have, all of us have the same population, and we have a certain rate of dying, how many number of death we would have, I observe. So if I say that I have equal number of young and old cases in both the hospital X and hospital Y. So if I have 50-50, so how many death would occur if my rate of death is 10%? So if I expect that 10% of patients who are young are dying in hospital X, how many number of death I would expect? Okay, so 10 times 10%, which is 0.1, times 50, which is 5 death. That is, okay? Similarly, if in hospital Y, if I have 50, so we're using the same population, the same standard population. So if I have 50 who are young people, but I know that the rate of dying in hospital Y in the young people is 30%. So how many number of that would I expect among the 50 if my rate is 30? So the probability of dying is 0.3, and I have 50 people. So I would expect that I have 0.3 times 50, which is 15. 15. And I do the same with the 60%. So if I have another 50 who are old with a rate of 60% of dying, 0.6 times 50. So I would expect 30 number of deaths. And here I would expect 45, which is 0.9 times 50. 0.9 times 50. So what I'm doing in the direct standardization, I'm using the population I'm studying, I'm using their death rate, okay? And I'm calculating the expected number of death if they have the same standard population, which is a population, it's a hypothetical population where I consider that I have half of them are young, half of them are old. So when I do that and I compare now I'm going to calculate an adjusted rate. Now I have 5 plus 30, I have now 35 deaths expected if I have the standard population. So what would be now my death rate in X if I use the standard population? Death rate, what's the death rate? Is number who died over the total population, which is 35 over 100, okay? So what is it? It's 35%, right? Okay.
Yeah.
How many expected death if I have the population, the standard population now? It's 60 over 100. So now, which is better? Which has higher mortality? So the higher mortality is hospital Y. So after using the same standard population, but using each population crude rate, the adjusted rate now are in the direction that we now expect. Because when we took those specific, age-specific, actually we noticed that group hospital X is better than Y. But now when we adjust, actually, we got to the same conclusion that actually hospital X now is 35% versus 60%. Okay? So this is direct standardization. I will stop here. So age adjusted is 35, 60%, and therefore the adjusted is, so the adjusted rate are not, again, these are not the actual rate of death, but these are adjusted that allow us to compare which is better than the other. So I'm sorry if I took until 5. I think I will get better with other session. So I will try to keep time. But this is a lecture that has a lot of concept to cover. So I hope that will be more efficient next time. ماشي كتير أسمع هيك. We don't have to make our slides. How many slides are left?